Good afternoon, everybody, and welcome to the Center for Practice Excellence Rounds. My name is Zubin Austin, and thank you for joining us today. Our topic today is digital tools engaging patients in their healthcare journey, opportunities for the role of pharmacists. If there were ever a timely topic, given the era of COVID-19 in which we live, this topic around how we can find alternative virtual and digital ways of connecting with our patients is certainly important. Our presenter today is Claudia Lai, who's a postdoctoral fellow at the University of Laval. Claudia is a health services researcher with over 15 years of policy and research experience within both public and academic environments. Prior to moving to a career in research, she worked as a senior pharmacist at the Ontario Ministry of Health and Long-Term Care and as a drug information specialist at the Ontario College of Pharmacists and the Ontario Pharmacists Association. She recently completed her PhD at the Institute of Health Policy Management and Evaluation at the Dalla School of Public Health at the University of Toronto. Her doctoral research explored tools for engaging patients and their informal caregivers in health and information exchange processes. Please join me in welcoming Claudia. After Claudia's presentation, our discussant today will be Marie Roche, and Marie will have the first turn to reflect on Claudia's presentation and give us her insights based on her experience. For now, though, please join in welcoming Claudia to CPE Rounds. Claudia, take it away.
Thank you, Zubin. Thank you for inviting me to speak with you here today. I would like to start by extending my sincere thanks to the frontline healthcare providers and essential workers who are working during this very difficult time. And I want to start by expressing that I am a patient advocate. And so my research approach is informed by my patient advocacy lens. And so in my work, I enter my research space as a learner with an awareness of the conceptual dependencies of power and knowledge. And so I believe that digital tools are very important because they enable patients to participate in their own healthcare process. And so for today, I will be talking to you about my doctoral research, which analyzed how digital tools engage patients. And specifically, I will speak to my first published paper from my doctoral dissertation on the mapping of these tools. This mapping can help us to conceptualize the different types of tools that inform the decisions that patients make about their health. And so this mapping is useful for looking at the different types of tools that are freely available on the internet and how they engage patients in different ways. We talk about tools and we talk about patient engagement, but there are different tools and patient engagement can mean different things. And through sharing with you how I use this mapping in my current patient-oriented research in home care, I hope to be able to show you how this tool can be applicable to pharmacists. And I will be ending today by sharing my views on the opportunities of how digital tools provide for pharmacists in how they can better support their patients with decision making. And I'm really looking forward to hearing from you about your experiences and whether this mapping makes sense to what you do. And so why study digital tools? And so last month, a US survey reported that 8 in 10 adults relied on digital resources in making big decisions. And so regardless of whether you search for information using Dr. Google, or look for information from authoritative health websites, or track health parameters using Fitbits, or participate on Facebook or Twitter to debate about medical interventions, digital tools have enabled individuals to better participate in healthcare processes. In fact, these tools that are freely available on the internet have enabled patients to access information where it wasn't readily available without this technology. And they also connect people with one another virtually anytime, anywhere, depending on needs and context. And so for my doctoral research, I was interested in studying it for one of two reasons. Okay, so my first reason was that I faced, I lost my vision some years ago, and I was faced with difficult decisions when I had to go through numerous surgeries, and I was in desperate need for information and support. I am very grateful to recover what I have recovered, and I could have landed in a better, a more optimal place. but I made my decisions based on what I knew. And so I don't have decision regrets because I made informed decisions. I was fortunate because I had access to clinical information from my drug information network. And I also had health literacy skills to understand the technical information. And so that is not always the case for others who rely on the internet for information for their unmet needs. The second reason why I decided to study, second reason why I decided to study digital tools is also because we have all this data sitting on repositories, which really haven't been optimally used to inform decision making. And so my idea at the time was to study patient engagement processes outside on the internet to inform some of the designs of the digital health systems for better engaging patients within the healthcare system. And so before I start talking about my research, and thank you, Zubin, for my kind introduction, I've had the opportunity to work in diverse environments, diverse healthcare environments. And so I wanted to give you some context on how I arrived at where I studied. And so my diverse background has enabled me to study research problems from multiple perspectives. And this has been particularly useful for the interdisciplinary research that I do today. However, when I was in drug information, I had access to medical references, journals, and databases to find evidence-informed information. And I worked with a team of really knowledgeable pharmacists as I supported the information needs of pharmacists across Ontario. And I'll come back to this at the end of my talk, because this is really relevant to what I see as the role of pharmacists. And so while I was I guess, in my drug information role, I moved to the area of policy, mainly because I had supported one of these pharmacists from the ministry. And it's through supporting her health and her information needs that I came to realize that my clinical role might be more impactful at the policy level. And so with that, I went to the government, and I have spent over 15 years in government, where I have represented the ministry on external committees, built partnerships, and developed led a lot of policy initiatives. But one of the initiatives that had a significant impact on me was the colorectal cancer screening program. In this initiative, I was tasked to design, lead, and deliver the program across Ontario pharmacies in a very short period of time with a limited pool of funds. And so at that time, we were just introducing legislative changes to laboratory requisitions, and we started to collect this laboratory data in repositories, which I was really excited about because I thought that it could be really valuable for improving patient care. And so from this, I had an opportunity to co-chair a working group to develop a health portal. And so although I had led a number of changes to existing information systems, I had no clue what a health portal could look like. And so needless to say, it was through this experience that I was introduced to the world of health informatics. And with this curiosity and interest for policymaking to have a greater impact, I went back to school to pursue a PhD and studied health informatics. Sorry about that, I'm not pressing the right button. In terms of my research experience, actually it was through this talk that I came to realize that I actually started my research in pharmacokinetics. I used to be one of those pharmacy students who would wear a lab coat and use the pipette and conduct my research using the HPLC. In fact, my favorite course was Dr. Utrecht's medicinal chemistry. I used to think it was fun timing myself metabolizing a codeine molecule to morphine molecule in multiple ways. I meant on paper, that is. And so what excited me more at this time was a course I took in health promotion, which introduced me to the social determinants of health. And so this had changed my worldview. And with this, I moved to the Department of Social and Administrative Pharmacy to train with a sociologist, Dr. Linda Muzzin. I am very grateful for the opportunity to train with Dr. Muzzin because she provided me with a solid foundation to build my research toolkit. So for my master's dissertation, I did a qualitative study on young pharmacists and how they applied their patient-centered care model in the community setting. And so for my doctoral research, I studied at the Institute of Health Policy Management and Evaluation and completed the requirements for a collaborative degree in Knowledge Media Design Institute. Building on my qualitative research skills, I studied at meso level. And what I'm going to be talking to you today are findings from the qualitative study that I did in patient platforms. But more currently, I am doing a postdoc at the University of Laval, where I'm learning to work in French. And so I wanted to share this with you because it's through this experience which has really, really taken me out of my comfort zone, because now I have a better appreciation of the challenges that individuals face in learning a different language, as well as sometimes we take it for granted that we work in an English-speaking world. And so expanding my research toolkit, my postdoc is using patient-oriented research approaches, using mixed methods. And actually today, I actually have notification from my first publication from this research. Sorry, I keep pressing the wrong button. And so I needed a unit of analysis to do my study. And so one of the places where you might find digital tools to study are what I refer to as patient platforms. And so patient platforms are simply health-specific websites that offer tools to engage patients with social media components to support their learning. And so I studied patient platforms that were freely available on the internet without upfront charges. And so while they share commonalities with platforms such as Facebook or Twitter, because they offer internet-based channels for people to share content broadly or narrowly, they were health-specific, and they offer tools to engage patients in their healthcare process. But despite the potential benefits of platforms, and before my doctoral research at least, little was known about what they were trying to achieve, what they were designed to support, and how they attempt to achieve their goals. And it was my doctoral research goal to address this knowledge gap. Now, in terms of how I did this work, I used qualitative methods to study a proposed selection of 11 patient platforms, which were chosen to partially capture variability across a number of attributes. And so the idea here was to choose platforms that supported a broad range of users who might have high health, but different information needs. And so with the visual and textual data I collected on these platforms, I mainly collected, I didn't say mainly, I only collected information in the public domain. And so the data was systematically tracked and rigorously analyzed using framework analysis, which is an analytical approach that has been used for applied policy research, which offers a procedure for sifting, charting, and sorting material according to key issues and themes. And since there was no previous framework to analyze patient platforms, I adapted a framework, a patient engagement framework, which was intended for applying to health information systems within the healthcare system, at least the system in the US. But I also adapted this my analytical framework with concepts on the clinical decision-making models. And so with this, this is the patient engagement concepts that emerged from my study, which was grounded in both the literature and the data. And so when we talk about patient engagement, we talk about patient engagement as if it was just one thing. But I guess what I wanted to really stress here is that, at least in terms of the tools that I was looking at, I looked at how those tools engage patients in 5 different ways. And so I don't want to get into the details of each of those 5 ways, but I wanted to just highlight that some of the tools that were meant to inform patients were coded that way because they really weren't intended for decision making. Tools that were coded for involved patients might help patients make decisions, but there wasn't really sufficient information for problem-solving tasks. Whereas tools that might empower patients with decision-making and problem-solving tasks, they would be coded as empowering patients. And beyond that, at least in the digital world, there were digital tools that actually could be used to empower not just one patient, but a community of patients by connecting them with one another for information and support. And so the last category, tools that supported the partner with me category, reflected tools that could actually patients could actually use to partner with their healthcare provider in collaborative decision-making processes, which are based on shared learning. Shared learning meaning that they could be sharing clinical and also non-clinical experiences. And so in terms of the findings of the research, the digital tools on the patient platforms that I studied were coded according to 3 types. And so these types I know they sound kind of simplistic, but when we look at digital tools, one way to look at them is the information flow from those tools. And so in terms of one-way tools, these are tools that are really really meant to disseminate information. And so the source of the information is the platform. And so the information typically goes from the platform to platform users. And so with two-way tools provided information to users that were based on the information that they collected from individual users over time. And so an example of this would be like self-tracking tools. And so the third type of tool, community tools, or multi-way tools, they collected information from multiple users. An example of this would be like discussion forums, where a number of individuals can share information together. And so one-way tools, while they can be engaging patients as content readers, two-way and multi-way tools allow patients to actually participate in the information exchange processes. However, they typically require people to sign up for a site account. And so while the platforms were freely available without upfront charges, the registration process typically will require people to provide a minimum amount of personal information, so such as their email address, and consent with terms of use, which means privacy policies, as well as other policies. And so, as you can imagine, in my doctoral research, besides learning about how these tools engage patients in their healthcare process, I also discovered how these tools really are not as free as they might seem to be, because all of these 3 types of tools and all of the platforms that I studied, regardless of the ownership type, collected data from users, which can support artificial intelligence processes. And so this week, I'm in the process of submitting a manuscript that talks about the income generating processes. And so I'm just going to go through in detail with the 3 types of tools and how they can engage patients. And so I wanted to just at least point out here, one-way tools disseminated a vast array of different information to engage patients. Some of the information may be evidence-based, some of them may not be as evidence-based, and some of them may not even be evidence-based. But these tools engage patients in different ways. And so in the involved category, for example, and if we think about it as pharmacists, when we provide, sorry, I should start in the informed category. So when we think about when we give information to patients to inform them of something, that can engage them in the informed category, which is very different from giving information or providing information to patients, for instance, such as side effects on a medication, which can help a person decide on whether they want to take a drug or not based on that information. And so the second category, the involved B category, engages patients in ways that can help them with decision-making tasks. This is very different from information that's provided to patients in the empower category, which can actually help patients with both decision-making and problem-solving tasks. For example, a lot of these platforms provide patients with access to medical references, which may not have been readily available in the past. And so with these medical references that are sometimes written for individuals with higher health literacy levels, some patients might use them before going to visit their doctor. However, some people might actually use them in place of going to their doctor. And so if you can imagine in our digital world, where it could potentially be possible for people to order their own diagnostic tests, or perhaps even order on the internet drugs globally. You can imagine what implications this might have. I also wanted to share with you, in terms of these one-way tools and the information that they were sharing, a lot of the information, it really ranged in the source of the information. Some of the tools were used to share information from reputable sources such as FDA or the CDC in the US, or they could be used to provide information that was produced by what appeared to be like medical experts or the platforms themselves. But they also were used to produce a sort of share content that was produced by the platforms through educational grants or through sponsorships. And in one case, I actually found one of the platform advertising their editorial page for posting sponsored content written by themselves, or it could potentially be written entirely by the sponsor. And so in the manuscript that I'm submitting right now, I'm talking about the income generating processes because they can actually support other mechanisms, such as direct-to-consumer advertising. Sorry. The second type of tool, two-way tools, again, an example of this might be tools that help patients collect their data, such as their blood glucose over time. And so these were the tools that were these were the only tools that were I guess coded for aligning with all 5 patient engagement processes. And so in the case of where you have a self-tracking tool, these can enable patients to track their own data over time and allow them to actually monitor their condition without relying on their healthcare providers to do so for them. And so for this reason, they were coded as empowering patients. But these self-tracking tools can also generate summary charts of their data over time, which they can then subsequently share with others, which then in those cases, they would support the patient engagement process of support my patient e-community category. And so these tools were really, really powerful because they allowed patients to connect with other patients like themselves, other patients who might understand what they're going through and have the experience and knowledge to support them through their healthcare journey. These tools can also produce charts where some patients might actually print them and take them to their healthcare provider, like their pharmacist, and to talk about their patient goals. And so actually, I was just speaking with a pharmacist last weekend, and she was sharing with me how during this COVID environment, her patient has now given her access to her self-monitoring, self-tracking tools so that she can actually provide patient care virtually with this patient. And so beyond the two-way tools, what I want to talk to you next about are multi-way tools. And so again, multi-way tools are tools such as discussion forums. These tools were the ones which I found to be the most powerful because they can connect patients with one another. And so while some individuals might share their personal journey of their illness, collectively, a number of patients talking about and reflecting on their journey, that collective experience can reflect the illness journey of a number of patients or a group of patients or populations of patients. Also, these tools allowed users or patients the ability to share content with small groups or even share content widely in the public domain. And so they enable patients in some cases to share and build knowledge, which Scardomalia would refer to as knowledge building. And so while I have focused so far on my talk on the information side of things, all of these platforms that I studied, they also connected users in communities, or what they refer to as communities, which were promoted for being a safe and supportive environment for finding information and support. And so within these so-called communities, patients can actually participate using an online identity, which they come to trust over time. And so they might determine from themselves what might be trustworthy information based on a different set of parameters which they use in these online communities. And so with this in mind, they can also share information which may not be evidence-based. And so put more bluntly, they can actually share what I guess we could call fake news. And so what I wanted to talk about in terms, reflect on the implication of this is that a recent US survey published a couple of weeks ago found that 2 in 10 US adults gets most of their political news through social media. And with this group of people that relied on social media, they reported having seen, the majority have reported having seen some misinformation about the coronavirus. And so within these groups, they also seem to be less informed about the timing of when they're expecting a coronavirus vaccine. Many of them reported that a vaccine would be available in the next few months. And so the WHO, and this, I've taken this screenshot from the WHO. The WHO referred to this as the infodemia of misinformation. And so in our current crisis, this information can not only cause harm directly to individuals, but they can actually cause behaviors which can exacerbate the spread of this virus. And so while Facebook and Twitter might be trying to respond to this in recent months by trying to bar users from posting misleading information, there are so many other channels where patients are sharing information. And so as healthcare providers, I think that it has become increasingly important for us to play a role in trying to help patients sort through the information that they're receiving through these various sources. And so what I wanted to end with you today is that this mapping that I've shared with you, it has given me at least a way to label tools. That tools are not just tools. I mean, we have to look at those tools. And so this is a way to label the different types of tools that might be available freely on the internet, as well as talking about what we are really talking about when we talk about patient engagement. And so this concept, I've actually been applying it to my postdoc work, where I involve patients in my research throughout the research process. And so it's actually pretty exciting when I actually talk to my participants and ask them to share with me what they feel they need for better decision making. And so I want to share with you what I've learned through one of the participants who uses digital tools to manage his health issues. He uses a portal to journal as a health journal, which is accessible to his healthcare team. And so when he has a problem, he will go to the internet to do his own research before he goes to his doctor. And so he will actually, and he showed me this. He showed me a list that he goes to when he showed me one of his recent lists that he had before he visits his doctor to talk, so that he focuses his conversation with the doctor. And he doesn't actually expect his doctor to always have the answers to his questions. However, he partners with his doctors during his visit as they try to problem solve his problems together. And they might even use the internet as a resource as they work together in their appointments. He also told me about how he goes to check his lab results before his doctor appointments. And so, for example, when his INR is off, he might actually go to the doctor appointment and suggest changes to his warfarin dose. And he says typically the doctor agrees with him. So he doesn't actually do this on his own, but he does this in partnership with his healthcare team. But he also points to me that most patients don't have the health literacy skills to do what he does. And so there is really a really critical need for patients to increase their health literacy levels in order to participate in their healthcare process. But in my current research in the home care field, the older adults in my area of research, many of them are faced with disabilities or maybe even language barriers that might get in the way of their participation. And so for them, we have to really reflect on how we want to help them and partner with them in their healthcare process. And so I want to share with you also what I learned through one of my interviews with one of my participants in my postdoc research. In the beginning of my interview, this participant told me that he doesn't make decisions on his health, about his health. And he tells me that his wife makes all his decisions. And at the start of my talk, I would actually think that his preferred role would be that first category, the inform me category, as I would think that he preferred a more passive role in decision making. However, it was through my interview with him and talking to him with my research questions and really trying to listen to him in the best way I could, that I came to realize that he really wants to be involved in all of his health decisions. And really, he didn't want to be in the inform me category. He really wanted to be in the partner with me category, even though he didn't actually have that language when I first started speaking with him. And so he had a physical disability, a real physical disability, where he lacked voice. And I had to take, I guess, a lot of measures to try very hard to listen to him in order to have come to understand that he really wants to participate. And so I guess in my research, I am excited at looking at not just what they need for better decision making, but also challenging our assumptions on for whom and how and what is defined as knowledge. And so I'm very interested in building on what I'm learning from these individuals, as I'm looking for, I'm putting my attention on building the capacity for more older adults to actively be able to participate in their healthcare journey. And so in terms of opportunities for pharmacists, I feel that I've gone right back to my early days as a drug information pharmacist. And I remind you that that back then I had a vast array of information and a whole team of really knowledgeable, awesome pharmacists to support my work, as I supported the pharmacists across Ontario. But today, I mean, I look at what's happened today. Patients have access to a vast array of information. I mean, some of them being more evidence informed than others, and in fact, some of them are not evidence informed at all, as I've mentioned earlier. But they actually have a whole network, a whole group of peers who can support their learning. And so, what I do think for pharmacists is that we have this huge opportunity to partner with our patients and help them understand that whole vast array of information, because not all of the patients have the health literacy skills to make sense of the information on the internet, nor do they have the critical skills to help, the health literacy skills to critically evaluate whether the information is evidence-based or not. And so, particularly in my postdoc research, I see all these all these opportunities for pharmacists to make a real difference in supporting an increasing number of older adults who are living and aging at home, and they are faced with a lot of difficult health decisions. And so with that, I want to end by acknowledging the many mentors that have really, I really wouldn't have been able to do the research I do today without their generous support and mentorship. I also want to acknowledge Institute of Health Policy Management and Evaluation and the University of Toronto for offering me my U of T fellowship, which supported my doctoral studies, as well as my postdoc studies is supported by a CIHR grant and an unrestricted grant from SE Health. And so with that, I want to end with a discussion of some of these digital tools. And I really want to hear from you whether this mapping makes sense to you or not, whether it applies to your work. And yes, and I'm hoping that you can join me and Marie after this talk in a discussion where we can actually talk more interactively in a discussion forum. And so for those of you who might not be able to join us in our discussion, please, if you want to, I'd really be interested in hearing from you. So here's my email if you wanted to continue this discussion. Thank you.
Okay, thank you very much, Claudia, for a very interesting presentation and a really important way of looking at resources that are, of course, an increasingly important part of our world and our practice as pharmacists. I'm going to turn it over first to Marie Rocky, who is our discussant for today. While Marie is discussing her reflections on the presentation, I would encourage all of the attendees of today's rounds to take Claudia up on her offer and ask her questions. To do so, simply type into the chat box in the program your question. Annalise will be our moderator and will read the questions out following the discussant period with Marie. Let me introduce our discussant for today's presentation, and that is Marie Rocky. Marie is an associate professor at the Leslie Dan Faculty of Pharmacy and a leading luminary in the area of health informatics, not simply at our university, but nationally. Marie has held leadership roles in developments of a wide variety of information repositories, including most recently work associated with Truth and Reconciliation and the Health Informatics e-resource for the Association of Faculties of Pharmacy of Canada. Let me turn it over to Marie to offer her reflections for about 10 minutes to ask questions of Claudia, and then we'll turn it over to everybody else to ask their questions. Please type in your questions now into the chat box. But first, Marie.
Thank you, Zubin, and what a lovely introduction. Thank you. And Claudia, what an illuminating presentation. Of course, I hadn't seen it ahead of time, so I had spent some time preparing today, and I think I'll be able to perhaps extend the discussion through the lens of COVID, through the lens of Ontario and digital health. But I wanted to commend you for the framework, because as I took notes on it, I believe that it's really relevant in terms of not just tools, but services that we're starting to see emerge through COVID, and a lot of websites and a lot of platforms. And I think there's some really interesting extension of your tool emerging. And I'm using a lot of E's, and that's a bit deliberate with eHealth. Claudia mentioned that one of her supervisors, and she mentioned this to me on the phone this week, was Gunther Eisenbach at U of T, and he's a sort of the seminal individual in consumer health informatics, which is this area, and he coined a term called APO mediation. So that's APO-mediation, and it's not a generic drug name. It's this idea that in the information age, when information is flowing freely, healthcare providers no longer stand between the patient and the information, but rather they stand beside them, and their role as kind of a filter and an interpreter is something that Claudia obviously resonated with Claudia, and I think that it's an important thing that we need to be teaching our, not just the profession, but our students. I've heard that in nursing schools now they are teaching them to when they're engaging with patients in their visits, one of the first questions to ask them is, what did you read on the internet about that? So it really kind of normalizes behavior in the digital age. I wanted to also mention that at a recent digital health conference I attended, there's some new lexicon emerging that I thought was worth sharing. It's to consider patients no longer patients or consumers, but digital citizens. And there's lots of talk about a citizen-owned digital identity. That's Don Tapscott's term, where patients, citizens own it, control it, manage it. And Claudia talked about tethered personal health records, which are quite often associated with an institution or an organization, and that the patient controls the access to. And it bears mentioning right now that, of course, being in Ontario, we are the have-not province with respect to electronic health records. So that means that information continues to be fragmented and siloed, although connections are being made. So when I think about information in terms of patients, I think of information related to their conditions, and Claudia's work revolves around that, and information in their records, but then also access to the healthcare system. And I think that this is where, with COVID, we're seeing a lot of new platforms emerge, and I just wanted to share some of those thoughts with you today. This is the area of telehealth and telemedicine, and its time certainly has come. In 2014, a study listed the following as priorities for patients, and the extent to which they had been satisfied until now is probably been very modest. So that was the idea of e-visits. And mainly these were offered through the Ontario Telemedicine Network, and in specific specialties such as dermatology and psychiatry and even stroke, but where physical assessment could be done at a distance, and in the case of telestroke, access to a neurologist. The idea of e-refills, and again, this was done to some extent by mainly corporate chains. The idea of e-views, which Claudia talked about, patients having access to their personal health records is a very large and emerging area. And actually the focus of Canada Health Infoway's new positioning with Access 2022, and if I can share these email or these websites afterwards, but Access 2022 talks about a new age for patient empowerment and patient engagement for these types of portals and information sharing that Claudia talked about. The idea of remote patient monitoring was the fourth idea, and Claudia talked about older adults, and these programs tended to focus on conditions that were sort of later in life, such as congestive heart failure and COPD. And interestingly, when you look at those programs, these were older adults who were quite, after some training, quite fine with the technology. And lastly, the idea of e-scheduling, which is again, an affordance for access, and one that we saw so infrequently. But in the last 2 or 3 weeks, things have literally exploded. And the biggest shift, I would say, has been in primary care. The Ontario government is now paying for digital visits to prescribers. Many practices have moved online. And again, if you look at their platforms, they're very telling in terms of Claudia's work, because they're very patient-centered, I think, in their language. At least that's my observation. We're starting to see some interesting what's the word that I had written down here, partnering, I guess, with Shoppers Drug Mart and Maple, which is a primary care service. Shoppers Drug Mart is so part of their branding, and this is a primary care virtual office visit service. Claudia mentioned communities and conditions, and a huge area in this space is that of e-mental health. And so we are seeing companies like Silver Cloud, which is being offered through our Green Shield plan at U of T, and Beacon, which is being apparently offered to all Canadians at no charge. This begs the question, and I'm sure Claudia has some interesting views on this, about trust frameworks, which are now, it's kind of, that's the language and lexicon emerging around confidentiality and privacy, and what happens with this data, with this big data. And there's a very interesting debate going on right now about, well, healthcare is publicly funded, so the big data can belong to the government, and I'm simplifying things here. Websites that were just recently launched and now are perfectly well positioned, like iamsick.ca, which is a real-time sort of hot map of where the wait times are. And interestingly, today, looking on it, in terms of information provided, Claudia, they have the assessment centers for COVID-19, and I didn't think those were being made public, but that really speaks to, information flowing freely. Silver Cloud. The other aspect that I think Claudia touches on around patients being involved in their own care is, there's also a small subset of patients in the blogs who talk about their health anxiety, and this is also a very interesting group to think about, who identify as cyberchondriacs, so cyberchondriacs, whose anxiety is worsened by the information that they see online. But in a lot of the forums, they actually support one another in helping to interpret and filter their own symptoms and support one another. Some other changes that we've seen, so that's kind of more broadly across the health system and in medicine, but in pharmacy specifically, we are now able to provide meds checks, medication reviews virtually or over the phone. This is a huge shift. Formerly, until 3 weeks ago, they had to be done face-to-face. And there was a very unfortunate bulletin come out from ISMP that talked about a student doing a BPMH and being exposed to a COVID positive patient. Yeah. Mm-hmm. Well, yeah. And so, but of course we could have seen that coming, and I would have been surprised that a student would have been put in harm's way. I've told our students that's not going to happen. In terms of other services, prescriptions which historically have been sent by telephone or fax or paper, and increasingly electronically through Prescribe It, an e-prescribing platform, have been challenging for community pharmacists because Prescribe It is not fully enabled across the country by any means. And so a number of physicians started to email their prescriptions to pharmacies, and our college, I believe, was in the first week or so of the pandemic not supportive of this. It was made very clear that this was not an acceptable way to transmit a prescription. However, they walked that back a week later, as they should have, in my view, to allow it, although they took great pains to mention that this is temporary. So I think all of these examples are very interesting because really patients are at the center of this, and it will be very interesting to see at the end of all this, all of the research that will be underway in terms of, you know, patients' experience, patients' access to systems and services, and I think importantly, what types of services they prefer. So for example, I know that of one pharmacy, many pharmacies are offering delivery services augmented by the good old telephone, but also some are doing curbside pickup, which sounds a lot like a big box store, but you know, is necessary for drug distribution. So I think, you know, to come full circle, I think that the empowerment of patients through all of these shifts in the delivery of care will be very important in terms of the transformation that is underway, and certainly bears a lot of studying.
Well, thank you very much, Marie. Some really interesting insights there. And in particular, I think all of us are going to go away from this thinking about the term cyberchondriacs. That's a very interesting concept. Claudia, did you have any specific response to some of Maria's comments before we turn it over to the audience?
Yeah, hello?
Yes, go ahead.
Sorry. Yeah, no, that's actually, Marie, that was like a fantastic overview, I guess, of digital tools in our current environment that we're in. Fantastic overview. I just wanted to touch on a few of the points that you said. And so actually, I actually feel bad because I think that I forgot to acknowledge Gunther Eisenbach. Yes, he does shape a lot of my research, and he had coined the term apomediation. And so I guess when we think about all this, with the way that it's through Gunther's model, with the way that the digital tools can enable patients or patient empowerment, there is where healthcare providers may have been the mediator of information in the past. Gunther would argue that there's a disintermediation process going on here, where patients can directly get the information themselves. Mm-hmm. And so, I think what Marie said, I think that's a very, very important point for us to think about, is that our role through this is changing. And I think that it will change actually after COVID-19, because some of the things, especially that Marie, you had mentioned, I actually think that in some ways we will be changing some of the way we. I think that some of the things are going to change how we operate. We're not actually going to go back to the place we were before. Mm-hmm. And what else did I want to talk about? Yeah, and I guess I love that hypochondriac reference, Marie. And so yes, there are going to be a lot of patients who, because a lot of hypochondriacs, at least that term, they learn about a diagnosis and then they automatically think about having that condition. But that being said, there is some concerns also with that when hypochondriacs now can use these digital tools and convince themselves or do a self-diagnosis of what they think that they have and never even see a healthcare provider. And as I was trying to allude to during my talk, I think that there's huge health implications from that, because ultimately, if they live in Canada, they could have health consequences that can actually have impact on our healthcare system. And so, yeah, did you want to add to that, Marie?
No, just in terms of the tools, I also wanted to mention, and sorry, yes, I totally agree. And I don't mean to be dismissive of individuals' right to access information. I just think it's fascinating to see them make sense of the information. And Claudia, you had a great example of patients going to their patients with their lab results through Life Labs. And I think everyone's adjusting to this, new age. But the other tool that I think is very interesting in terms of COVID are all of the hot maps and digital visualization tools and statistics. And I think, when we look at some of the silver linings of all of this, it's people understanding epidemiology or beginning to understand some fundamentals, right? And flattening the curve, and just so much interest in the data and the numbers. People coming in for daily, twice a day for the stats is very interesting.
Thank you both, Marie and Claudia. And let's turn it over now to our audience. We have a couple of people with questions. Our first question comes from James Marshall Bowen, and I'll turn it over to Annalise to read his question. Annalise?
Thanks, Zubin, and thanks to both Claudia and Marie for your comments and presentation on this topic. So Jim's question is, Claudia, thank you very much for your informative presentation. Given your many pharmacist roles throughout your career, what role do you think the government has to play in this domain along the lines of the release of personal data and sharing of information?
So I think that's a really good question, because I mean, we live in a world where we want to protect people's privacies. And so what Marie had mentioned also, sometimes, sorry, can you hear me?
Yeah. Okay,
sorry, I just thought I heard a beep. So I guess what we have to think about is the ownership of that data sometimes. And so, so yes, within government, so that this is what I honestly do feel that, and this is the crux of why I went into this type of research, because there are so much data that in these repositories that actually can have huge impacts on improving patient care. And so the sharing of that data, I mean, I think that that data can inform, and I've seen how data sharing outside of the healthcare system can have huge impacts on improving people's ability to manage their health condition. And so I really hope that within our healthcare system that we will eventually be able to use that data in an, I guess, protected way where we're not actually, people don't lose their privacy, but then enable some people to be able to use that information to improve, to actually participate in their healthcare process. And so that also brings up what Marie had spoken earlier, in that some of these digital tools actually collect a lot of data. And so this is one of also my concerns as well, in that some of these free tools that are on the internet, patients actually have to give up their data in order to be able to use these tools. And I've seen how these tools have a huge impact, huge positive impact, at least for a lot of people who don't have anywhere else to find this information. In fact, even if within the healthcare system, if we wanted to find some information, sometimes those tools can find things that are not published in the medical literature. And so with that saying that, yes, I think that there needs to be some sort of mechanism to protect people from that too, right? Because there are some consequences that can happen to people when that data is then sold for profit.
That's great. Thank you, Claudia. Our next question is from Jen Lake, who presented with us last week at the CPE Speaker Series. Her question, I think Claudia and Marie, you can both weigh in on this. Maybe Claudia, if you want to take a first stab. Jen's question is, one of the aspects of Claudia's work and Marie's discussion is digital tools reducing the power differential between healthcare providers and patients. How hard is it for healthcare providers to be humble and accept patients and publicly available resources as high quality information and evidence in decision making? And how do we support current pharmacists and current students with that?
That's a great question, Jen, and that's actually the crux of what I'm researching right now. I actually do think that pharmacists need to, I think that pharmacists can actually play in this role, because not everybody has health literacy skills that pharmacists have. There is a huge need actually right now for people to be supported with this whole vast array of information. And we do have to be humble, because patients have a vested interest in their own health. They can access information as fast, if not faster, than we can. And they can't, and as I was saying in my presentation earlier, the story that I shared about that patient that partners with his healthcare team, that interview that I had with that participant happened way before COVID-19. And so people were doing this. The doctor was humble enough to actually partner with this patient to learn together. And yes, I do think that actually that is a model that we can embrace, at least look at and explore in our future of health, future way of helping patients. And Maria, I don't know if you have anything else to add.
Yeah, I agree, Claudia. It is the grand challenge. And Jen, you know more than most that, you know, teaching that humility, teaching that willingness to listen and believe that the patient has a right to know is I think a big shift for a lot of professionals and a lot of students. I think that, you know, the danger in not being open to it and not having that humility is patients won't share information. They are watching cues. I've had patients tell me that they would never disclose everything they've read to another healthcare provider for fear of being chastised or ignored or dismissed. And so and I think, having said that, I think a lot of healthcare professionals do it very well, and I think there's a lot of change but that is happening, but it'll be a huge shift and is necessary.
Thanks to you both for weighing in on that. Jen also thanks you for responding. I think we have time for one more question before we wrap up the session today. The last question, we kind of have a two-part question from Peter Pennefather. The first part of the question, how can emergency policy changes to enable empowerment of patients and their circle of care during this pandemic crisis outlast the current crisis?
Peter, good question. Can you repeat that one more time?
Yeah, so how can emergency policy changes to enable empowerment of patients and their circle of care during this pandemic outlast the current crisis?
Well, I actually think that in some ways, I mean, I definitely think that it will be outlasted, because once these channels are open, I don't know that this is actually from my policy of my years of policy working in the government. Often what happens is that once we have new ways of doing things or funding drugs, even though that crisis is no longer there, that allowed for that drug to be listed in the first place, that drug then continues to be reimbursed. And so I expect that all these emergency policies that are in place right now to enable some of this to happen, I expect that many of it will change. Although, I mean, we have to put it into perspective as well, because, I mean, for instance, Marie was talking about using emails that are not HIPAA compliant. And I actually was talking to the pharmacist who was saying how they're using, I guess, social media tools that are not HIPAA compliant. So some of it might be like modified. But I actually think that we are changing how we do things. We don't really go back. Marie, do you have anything to add?
No, nothing to add. Just agree that, you know, it'll be political, it'll be economic, right? This is a whole new delivery model in affecting human resources as well. Supply chain, logistics, it'll be political, it'll be economic, it'll be health, it'll be patient driven. It'll be fascinating.
Well, thank you both very much for a very interesting and important CPE rounds given the current situation. For those of you who would like to continue the conversation following conclusion of the rounds today with Marie and with Claudia, please join in at the Blackboard site that has been forwarded. In the meantime, please join me in thanking Claudia and Marie for their participation today, and in thanking Annalise for being our moderator and for organizing our session. Please join us for our next CPE rounds, and in the meantime, everybody have a great, safe, and appropriately socially distant long weekend. Thank you very much. Bye.
Thanks, everyone.
Thank you, everybody.